Hello everybody, my name is Rob Foll. I'm very pleased and proud to be part of the Vets for Ukraine 2022 webinar series and campaign. Although none of us want to be in a position where we're having to raise funds to help the poor people of Ukraine who are experiencing untold suffering, over the past few weeks what's happened has been truly incredible. We've now had 19 amazing webinars delivered by brilliant colleagues. And these webinars have been viewed by literally thousands of colleagues from around, particularly Europe, but now increasingly across the world. And very pleasingly and humblingly, this has now led to the raising more thousands of pounds, which is directly going to help the people of Ukraine. The quality of the webinars has been amazing, and I hope you've enjoyed them as much as I have. This evening is going to be no exception of that, I have no doubt. This evening's webinar will be delivered by Professor Dick White, and I've had the privilege of working with Dick for now over 20 years, so it's a lovely touch for me that he's delivering the 20th webinar of our series. Dick is one of the most outstanding and most influential, important veterinary surgeons in our profession, I think it's fair to say, in the past 40 years. A man who has truly improved the profession in so many ways for the benefit of all of us, for our patients and our clients. So, I'm really looking forward to this evening, and I hope you enjoy it. However, we're not going to stop there. The response of the people, of everybody actually, to our webinars is a little bit like the Eurovision Song Contest. It's just showing what people can do when we get together, and we can really all truly make a difference. So what I ask is that if you haven't yet had the chance to share or like our webinars, that you do share and like them on all of the social media platforms, Facebook, LinkedIn and YouTube, that you tell your colleagues and encourage them to view the webinars too. And if you are in the position to do so, however little or much you can give, we'd be so grateful for a donation that will really go to benefit the people in the Ukraine. So, thank you for everything you've done. Thank you for being part of this. And let's sit down, enjoy this evening's webinar with Professor White, and we'll look forward to more webinars coming over the next few weeks. Thank you, everyone. Have a good evening.
Good evening, everyone, and welcome back. I'm Daniela Murgia from Vets for Ukraine 2022. Before starting, I'd like to congratulate with Kalush Orchestra for winning the European Song Contest. This is an example, as Rob was saying, of where we could what we could achieve if we join our forces. Today is a special day. This is a special live because exactly 2 months ago, 15 specialists decided to put together, to join together in what is Vets for Ukraine 2022 to offer a series of webinars offered to vets, student vets and vet nurses in order to create a sort of community, let's call it cultural movement, to create a group to support our friends or the people in difficulties in Ukraine afflicted by the war. These 15 specialists became then, with time, nearly 30, and the decision to put together our forces was to try to collect or to raise funds for the British Red Cross Society to help the people in difficulty in Ukraine with clean water, food, shelters, repairing schools, repairing hospitals, and all the to offer all the basics necessary things for them. So one of these specialists was one of the 15 original specialists was Professor Dick White, who very promptly replied to my request to my appeal to create this what we are doing now, and I'm very honored, and Vets for Ukraine 2022 is honored to have him tonight for this talk on the canine larynx, because Professor Dick White is recognized for his important role in the soft tissue surgery in the world, and is an example of innate leadership, exactly now in these times where the leadership has, like we hear everywhere talking about leadership and what we should do to become good leaders. Well, Professor Dick White is a leader in our profession, in our specialty. So I remember now about 4 years ago, I joined Dick White Referrals, and I remember it has been always my dream to join to work in this referral hospital that Professor Dick White founded at the beginning of the 2000s, and it is like an institution which was characterized or is characterized by 3 important words: excellence, trust, and care. So we will ask Professor Dick White what these words meant to him, but I just remember how important it was to me to join this team of international specialists and amazing people. So Dick White Referral is a family, and it will continue to be a family. So I think I won't be the one presenting or talking more about Professor Dick White, because I would like to give the opportunity to other people that have had the honor to work with him and to meet him to present him. So it is at this stage where I would ask Paolo to let enter in our live other colleagues. But before this, please don't forget 2 important things. Share the links, share our links, and try to reach as many people as possible, because if we reach many people, we also can raise funds for Ukraine. We are going live on Facebook, on YouTube, and on LinkedIn, and on Twitter, and also, so therefore share, and then don't forget to donate. If you are in the financial position, just donate, because every little counts, every little helps. And the link to donate is www.justgiving.com/vets4Ukraine. So please click on this link and do your donation. So yes, I think it's time to let our guests in. Paolo? Hello, Vicky. We have Vicky Lipscomb from the Royal Veterinary College. Hi, Vicky. Welcome back. How are you?
I'm very well, thank you. Nice to see you. Very excited about this evening.
So, Vicky, you have had the honor to work with Professor Dick White from the very beginning. Yeah, do you want to tell your story?
Yes. So, hi, Dick. I wanted to share that I first met Dick in 1995 as final year veterinary student at Cambridge, and mostly up until that point in my career, I really thought that I might be an equine vet, potentially equine surgery, but definitely equine. And the first rotation of my final year was soft tissue surgery in the small animal hospital with Dick. And that was one of the factors that changed my outlook completely. I absolutely loved the rotation. And I signed up at that point to spend my elective weeks over the summer with Dick, just scrubbing into more surgeries and watching him work. And I also realized you need a winch to about 10 people to get a horse onto a table, and there were things you can do in small animals that you just can't do in horses who are 800 kilos. But my eyes were opened to all of those cases that I saw, and I haven't looked back since. I have since that point, pursued soft tissue surgery as a career, and I still love it every single day. The variety and the work is something that I love to do. So thank you very much for introducing me down that path, and for everything you've done for the profession ever since.
Thank you, Vicky. This is very interesting because I haven't said that the very first time I heard of Professor Dick White was when I was a young resident in Munich. And I remember that my supervisor, Professor Mattis, asked him to join the vet school, also to the clinic, the hospital, because we had a dog with shunt. And Professor Mattis is an orthopod. So, and Professor Dick White came for the day and he did operate the shunt, and then he left. So, which was really the very first time when I heard his name. And then since then, obviously, he's a legend. So, Paolo, have we got someone else that wants to talk about or introduce Professor Dick White? Let's see. Davina, your microphone is off. You are mute.
You caught me out there. I was quietly sort of reminiscing, really. Hi, Dick. Long time no see. So I'm one up on Vicky, actually. I just worked out that I've known Dick for just over 2/3 of my life, which I'm not sure if that's a good thing or quite worrying. I met him 35 years ago, much like Vicky, also on my starting the final year rotation. And I also did my elective in surgery over the summer, working with him and John Holton, and never really looked back. I did dally with mixed practice, but for 2 years, and that was enough, really. Cesareans in the middle of a field in the pouring rain. Actually, this is really not the way to go. Actually, one of the things everybody talks about Dick and the sort of legacy of all the surgery, but what not everybody knows is that he's also done a lot of work rescuing moon bears from the bile farms, and worked on developing a practical solution to reversing the cholecystostomy fistulae that these poor animals had done on them, and then you have to reverse it in order to allow those animals to be rehabilitated and rescued. And he did the first surgeries and presumably has taught people how to do it going forward, and that was an amazing, innovative use of his incredible skills. So yeah, I'm looking forward to this evening.
Amazing. I didn't know this story about the moon bears, because there is a colleague, Claudia Hartley, that is still doing her journeys to China and other countries in Asia to do surgery on the cataract of these bears. Yes, it's a really great job. Thank you, Davina. So I don't know if everyone knows, Davina has been a past president of the ECVS, the European College of Veterinary Surgeons. And to honor Professor Dick White, we have invited the current president of the ECVS, Dr. Tim Greet.
Hello.
Hello, Tim. Welcome.
Yeah, it might seem a little strange that an equine surgeon is introducing a lecture on canine laryngeal hemiplegia, but just to explain a little that, I'm the current president of the European College of Veterinary Surgeons, of which Dick White and Davina are also are diplomates. But the most important thing is that in 1992, the ECVS was the first European college to be established. And I was amongst the group of surgeons who passed the first examination in 1993. The founders of that college were Professor Jörg Auer of the University of Zurich and a Dr. Dick White, then working at Cambridge University. They shared a vision that a specialist college would provide the opportunity of creating training programs and a certifying examination that ultimately would promote a better quality of surgery within Europe create a group of specialist surgeons. They were both diplomates of the American College of Veterinary Surgeons and had seen how the ACVS had driven up surgical standards in the United States and wanted to achieve a similar effect in Europe. 30 years later, the ECVS has almost 1,000 diplomates based in over 30 countries around the world, which is an extraordinary success story. However, this is not only Dick's only claim to fame, because having graduated from the RVC in 1976, he was appointed a clinical oncologist at Cambridge University Vet School, and he worked there for over 20 years, including a period of time at the University of Tennessee. And in 2003, he took a risk to set up a small animal referral hospital in what you might think was a rather unlikely situation at 6 Mile Bottom between Newmarket and Cambridge in East Anglia. Almost 20 years later, this has flourished and currently employs over 30 veterinary specialists in different disciplines. Dick has an extensive CEV, has published over 100 scientific papers, and is a recognized specialist by the Royal College of Veterinary Surgeons, the European Board of Veterinary Specialization, the American Board of Veterinary Specialties, and he lectures, as we all know, regularly at international meetings. The catastrophe that we all see that has befallen Ukraine has triggered a massive outpouring of sympathy from around the world. There's been a huge response from many countries trying to provide support to a nation fighting very bravely for its independent existence. The Vets for Ukraine 2022 initiative is one of a number of veterinary activities, raising funds, providing webinars given by veterinary specialists. And tonight, Dick is going to talk on laryngeal hemiplegia in the dog. As an equine surgeon, I've spent quite a large part of my career dealing with laryngeal hemiplegia in the horse, which is a common and important disease, frequently disabling athletic endeavor. It still represents a significant surgical challenge, which has occupied the time and attention of many surgeons, but has also fostered a collaboration around the equine world. And it's something which I think we're beginning to get to deal with in a much more effective way. So to finish, I'd just like to thank you, Dick, for your contribution to developing surgical specialization within Europe. It's been a huge achievement in setting up the ECVS, and I'm sure that everyone listening to this will thoroughly enjoy the webinar you are going to give in support of a truly worthwhile cause. So thank you very much, Dick, and very nice to see you, my friends from ECVS and elsewhere. Thank you.
Okay, so Paolo, I just had a message from Rachel. So she is also ready to come to the live. But in the meantime, so I just sent her the link. In the meantime, shall we introduce Professor Dick White?
Hello.
Hello, Professor.
So let me begin by thanking everyone who said such nice things about me. There was a point I have to admit during those introductory tributes where I began to wonder who the hell the speaker was tonight. It certainly wasn't going to. So thank you all for the kind words. And let me begin by saying it's a great honor to be able to contribute for Vets for Ukraine and to pay tribute to Daniela and Paolo, who've done so much to get things moving along. So, Daniela, are we going to start now? Or are we waiting for Rachel?
Yes, I think we can start. So I just wanted to double check with Vicky and Davina whether they are happy to stay with us, or just feel free if you have other but it would be great if you could stay with us. But I know that you are very busy as well. So
they've got Sunday night with the family.
Thank you. So we have a message from Kate Forster. So can you read it?
Yes, she remembers coming into work in pink dressing gown in the middle of the night to operate. And pink has always been my favorite color, as we can see from the color scheme tonight. I did a surgery last week and got into my pink scrubs that I've had for many years. And unfortunately, they don't really fit. I may have to get a new set if I ever operate again.
Now I have a story. When originally we were allowed to choose our own color of the scrub, the theater scrub, and I was clearly told by the dispensary people that I was not allowed to pick up the pink because pink was your color. So it's still not possible to pick up pink. Anyway, yes, I would say if you are happy to start, let's on. Yes, thank you.
Okay, so there we go. Have you got my screen now?
Yes, we have it. Yeah.
Okay, right. Okay, good. Okay, so tonight, as you've heard, we're going to talk about the canine larynx and specifically use a 3D animated model that allows us to see how the larynx works, and then to look at how we can use that functional anatomic information to take a more rational approach to how we manage canine laryngeal paralysis. So if we think about laryngeal diseases in the dog, they're relatively common. We see two important conditions. First of all, paralysis, which we associate with the medium and large breeds, and that's what we're going to focus on tonight. The other important condition being collapse, which we see in the brachycephalic breeds, and we'll perhaps leave that for another evening. So what we're going to do is focus on paralysis. We're going to look at how the larynx works, first of all, because it's only armed with that information that we can find a rational solution to the management of paralysis. So I think many veterinarians still look on laryngeal paralysis as a rather complicated disease. And I think there are three main reasons for that. The first is the functional anatomy is quite complex, that's for sure. Secondly, the clinical signs, I think, often can deceive people, and people are not certain that they're dealing with laryngeal paralysis. And thirdly, there is a perception that the surgical procedure is rather complex and should just be in the domain of specialists. So if we think about those points individually, there is no doubt that laryngeal function and anatomy is not easy to understand. And as Tim suggested, I left the Royal Veterinary College more than 4 decades ago, and I don't remember leaving the vet school with anything like a comprehensive idea of how the larynx works. So we're going to be using some 3D animated sequences tonight, which will help us to understand how the larynx works. Secondly, in terms of the clinical signs, we said the clinical signs are often subtle and insidious, and they are easy to miss. So we'll just review how to make a definitive diagnosis for laryngeal paralysis. And then thirdly, with regard to the surgery, many vets still think that surgery for laryngeal paralysis is too complex to attempt. I think if you have a thorough understanding of the functional anatomy of the larynx, then the surgery doesn't become quite such a worrying procedure. And it should be a fairly brief procedure, both in the operating theatre and for the patient's stay in the hospital. So let's begin by looking at laryngeal functions. And the larynx has 2 major and 1 minor function. The first major function is control of the airway diameter, As we see here, the larynx, the rema of the larynx opening and closing, and that controls the volume of air that can enter and leave the lower respiratory tract. Secondly, it protects the lower airways. And this is a point I think that's really very important. I think many veterinarians have a lot of misconceptions about how the larynx protects the airway. And this in turn has a knock-on effect in some of the misconceptions about the complications of laryngeal surgery. So hopefully we can address those tonight. The third function, the minor function then, is vocalization. And in the human species, vocalization is a much more important function than it is in our patients. So those, I think, are the main functions. If we think, first of all, about control of the airway diameter, during the respiratory cycle, during inspiration, the esophageal opening in the dorsal pharynx remains closed. And air then moves into the lower airways through primarily the nasal sinuses, but also, of course, in the panting animal through the oral cavity. And if we look at that schematically, the first thing we said is the opening to the esophagus in the dorsal nasopharynx is closed, and that allows air to move just into the respiratory tract, the lower respiratory tract. Sometimes, of course, as we said, air moves from the oral cavity without any of it entering the esophagus. Now, during the respiratory cycle, during inspiration, the larynx is open with minimal resistance to airflow. During expiration, it passively enlarges to allow outflow of the air. And then during the resting phase, it's partially open in a neutral position. So there are various positions the larynx can adopt to control the airway. The next function then, next very important function, is protection of the lower airways. And this refers during the swallowing phase, during which the airways are closed, so that the food bolus can move from the oral cavity through the pharynx into the esophagus. And again, if we look at the schematic, not a 3D, but a schematic, the first thing that we can see is that the nasal sinus is sealed off by the dorsal displacement of the soft palate. Now, the airway protection mechanisms then consist of the larynx moving, let me do that again. The larynx moving ventrally and being sealed off. Now, the misconception I think that many vets have is that the sealing off of the larynx is due to the vocal folds. And as we're going to discuss later on, that's really not very important at all. What is important is the role of the epiglottis. So the ventral movement and the epiglottic function are really what protects the airway as the oral bolus moves through into the esophagus. And I think this is a really important point that we'll come back to later on. The third function then is vocalization. It's an expiratory function. The glottis is partially closed, and the variations in tone and pitch are brought about by changes in the position and tension of the vocal cords. And as we said, in our species, vocalization can be considered a minor function. In the human species, and certainly in primates, vocalization is considered the third primary function. So let's now start to look at the anatomy of the larynx. And the larynx is essentially a valve between the upper and lower respiratory airways. And it comprises cartilages, elastin ligaments, intraluminal elastin ligaments, mucosa, which covers the elastin ligaments and therefore creates the folds, and then the neuromuscular structures. So let's begin by looking at the cartilages. And again, we can divide the cartilages into the major and minor cartilages. The major cartilages are, first of all, the epiglottis here, the thyroid here, and the cricoid here. And these three large cartilages together form a semi-chassis. The other anatomic structure to and to function within. The minor cartilages, first of all, are concerned with airway control. These are the arytenoids, of course, and with support. And that's the hyoid apparatus here. So this structure is concerned with support of the larynx. Let's begin by looking at the major cartilages, and we'll look at the epiglottis first of all, which is this rostral, spoon-shaped, some people say diamond-shaped cartilage sitting here. Its base is attached to the thyroid cartilage here, and that allows movement in a rostrocaudal direction. And this is the important bit for protecting the airway. So let's have a look at a 3D animation. So here obviously is the rema, the opening to the larynx. Here is epiglottis. Here's the epiglottic cartilage here. We can see it hinging about its attachment to the thyroid. So it has on its rostral surface a concave shape here in this direction. The tip, the dorsal tip, is called the apex, and then the other end of the cartilage down here is called the base. And the base is what's attached to the thyroid cartilage and about which it hinges. So as we can see here, it hinges about its attachment to in this rostrocaudal direction, and it's that provides the protective function, one of the protective functions for the larynx. Okay, now I've had three really very important messages. The first important message is this, that as far as respiratory protection is concerned, the first mechanism is this thing, the epiglottic hood that we've just seen in action. And the caudal movement of the epiglottis during the swallowing phase protects the laryngeal opening. That's one of the two really important respiratory protection mechanisms. We'll come on to the others in a moment. Really very important mechanism. Bear in mind the role that the epiglottis plays. Our next cartilage then is the thyroid, which is this horseshoe-shaped cartilage here. It's attached, as we've seen, to the epiglottis at its base here, and it's also attached to the cricoid caudally here. And this joint here is not entirely rigid, it's semi-flexible, so there is some capacity for movement. The rostral cornu of the thyroid is attached to the hyoid apparatus, and we'll see the role of that functionally in a moment. So the thyroid has this capacity for a small degree of movement between, with the cricoid. So here it is in 3D animation. We can see this horseshoe shape, the rostral and caudal cornu, the attachment to the epiglottis here, the attachment to the cricoid here, which allows a little bit of movement, as we said, and its attachment to the hyoid apparatus here. So this is the rostral pointer suspension of the larynx, and is really quite an important concept. The last of the major cartilages then is the cricoid, which is a completely circular or annular cartilage. It's attached to the thyroid, as we've seen. It's also attached to the first tracheal ring, and its dorsal surface provides articulation for the arytenoids up here. So again, in 3D animation, the arytenoids will arrive soon, I think. The cricoid will arrive soon. So the cricoid is this circular cartilage here with these points for articulation with the thyroid, and areas for articulation with the arytenoid cartilages here. And as we've said, it's firmly attached to the first tracheal ring, and this provides the posterior support. The rostral is the rostral with the hyoid apparatus. The caudal support is the first tracheal ring. Okay, let's move on to the smaller cartilages, the arytenoids, these small paired cartilages with multiple processes, and they articulate on the dorsal surface of the cricoid cartilage here. These are responsible, as we've seen, for controlling the airway diameter. And in 3D animation, here are the two arytenoids. They're connected by this sesamoidian band, and they articulate on this surface of the cricoid. There are multiple processes, the vocal, the muscular, and so on, and it has a very irregular shape. So this is its point of articulation with the cricoid. This is a concept of the sesamoidian band that joins the two arytenoid cartilages together, and it's the movement of these cartilages that change the diameter of the laryngeal opening during the respiratory cycle. So finally, then we come to the hyoid apparatus, and I have to say, for many, many years after I graduated, I was never really sure what the hyoid apparatus did. But it's a series of paired cartilages, as we can see here, which is attached cranially and dorsally here in the mastoid region of the skull, and then to the cranial cornu of the thyroid cartilage here. Now, importantly, the joints between these cartilages allow movement. And so the hyoid apparatus acts as a kind of suspensory spring to allow the larynx to move up and down in this direction, and also in a ventral dorsal direction. Let's just see that in an animation. So here's the attachment of the hyoid apparatus. See its structure. It's attached, as we said, dorsally to the mastoid bone and ventrally to the cranial cornu of the thyroid. Now, this is really a very important concept, I think, because I think many of us don't fully understand how the larynx moves during the respiratory and swallowing function. By virtue of its attachment to the hyoid, it can move in this ventral and caudal direction, which allows food to move over the larynx without risk of aspiration. So I said there were going to be three messages. Here's the second one. The important message number 2 is that in terms of airway protection mechanisms, the hyoid suspension system is the second important system. It allows the larynx to displace ventrally during the swallowing phase. And that's the other very important mechanism in terms of airway protection. We'll talk a little bit in a moment or two about the vocal folds, but I think the message you're getting is that the vocal folds are not nearly as significant as the hyoid suspension system and the epiglottis in terms of protecting the airway, as we perhaps have been led to believe. In terms of the ligaments and folds inside the larynx, we have the vocal, the vestibular, aryepiglottic, and ventricular. The one that we're usually interested in are the vocal folds, because the vocal ligaments, once they're covered with mucosa, form these folds, which are attached to the arytenoid cartilages and to the thyroid in the ventral midline. And these are what control the airway diameter. So if we have a look at these ligaments in situ, they should be appearing soon. Here are the vocal ligaments. They're attached to the vocal process of the arytenoid cartilages and to the thyroid in the midline, as we can see here. So here's the origin, here's the insertion of the ligament. And clearly they move passively with the arytenoid cartilages. As the arytenoids move, so do the vocal folds. So during the respiratory cycle, as the arytenoids are moving in this direction, so the vocal folds. And these delineate the opening to the larynx, the rima glottidis, of course. So the size of the rima is determined by the position of the arytenoid cartilages, which in turn determines the position of the vocal folds here. Okay, so let's just recap. During the inspiratory phase, with the arytenoids fully rotated, and I don't say lateralized, I say rotated, the rima is completely open and presents the least possible resistance to airflow. During the expiratory phase, the arytenoids fall passively towards the midline. The rima is partially closed, but not completely closed, and this allows air to move from the lower to the upper respiratory tract. In between the respiratory phases, the larynx is partially open, partially closed. It lies in this kind of neutral position. It's not completely closed. It's by no means open. And then, of course, we have a fourth position, which occurs during the swallowing phase, when the abducting intrinsic muscles move the arytenoids close together so that we have either a very small opening, a very narrow opening, or no opening at all. Now, I think in many people's mind, it's this mechanism which is the major protection mechanism for the airway. And here's really the third very, very important message, I think. That, I think, is a misconception. The glottic closure contributes comparatively little to protection of the airway. The rima glottis closes, narrows during the swallowing phase, but it ain't that important. And I think this has impact for us when we do laryngeal surgery for paralysis, because many people have this misconception that once the larynx has been surgically opened, you've lost a significant protection mechanism for the airway. We'll discuss the reasons why that's not the case in a moment, but let's just bear in mind that glottic closure is not that important. Okay, let's look at the muscles. We have intrinsic muscles which are responsible for controlling arytenoid movement, and we have extrinsic muscles which change the position of the larynx and also initiate swallowing. So there's no doubt that laryngeal musculature is potentially quite complex, but let's try and make it simple. In terms of the intrinsic muscles, they control glottic diameter. There are adductors which close the rima during the swallowing phase, and there are abductors which dilate the rima. And there are far more adductors than there are abductors. The only abductor we're really interested in, of course, is the dorsal cricoarytenoid muscle that we see here. So let's have a look at this, the most important muscle associated with abduction, in other words, opening the larynx during the inspiratory cycle. And it's this muscle here, the dorsal cricoarytenoid muscle, which, as the name suggests, originates on the cricoid, inserts on the arytenoid. And it's a sort of triangular shaped muscle. The broad fan shaped base inserts in the dorsal midline of the cricoid. So we have the paired dorsal cricoarytenoid muscles inserting here on the dorsal, posterior dorsal aspect of the cricoid, and then refine down to a point where they insert on the muscular process of the arytenoid cartilage here. And obviously, contraction of this muscle is what leads to abduction of the arytenoids and dilation of the rima. Okay, now there are lots of intrinsic muscles associated with adduction, but probably the most important are these two. First of all, this one, which is the lateral cricoarytenoid muscle. And again, as the name suggests, it originates on the cricoid and inserts on the arytenoid, but in this case, it inserts much lower. And contraction of this muscle is responsible for pushing the ventral part of the arytenoid medially. Okay, so that's one of the two important muscles. You can see where it inserts here. The second one is this one here, the vocalis muscle, which looks like a single muscle, but it's two muscles fused together in the midline here. And these loop around the dorsal part of the arytenoid cartilages. And contraction of this muscle is what's responsible for bringing the dorsal parts of the arytenoids close together. So those two muscles, the lateral cricoarytenoid and the vocalis here, are the most important in terms of adduction function. Okay, let's move on and look at the extrinsic muscles. The extrinsic muscles we can divide into a ventral group down here, which are responsible for changing the position of the larynx during the swallowing phase. And these are the thyrohyoid muscle, the sternohyoid muscle, and the sternothyroid muscle. And these move the larynx ventrally and caudally during the swallowing phase. The other group of muscles are the dorsal pharyngeal muscles, and these initiate the swallowing phase of the cranial esophagus. Now, all of these muscles are important, but particularly this group here, the dorsal pharyngeal muscles, because when we do surgery on the larynx, we have to make our way through these muscles. And of course, if we damage them, then we interfere with swallowing function. So these are the hyopharyngeus, the thyropharyngeus, and the cricopharyngeus. And we normally make our approach through this one, the thyropharyngeus, and we need to do it in a way that does not produce lasting damage, which interferes with swallowing. So here are extrinsic muscles. And first of all, we have this ventral group down here. These are responsible, as we said, for moving, bodily shifting the larynx during the swallowing phase and getting it out of the way of the food bolus. The dorsal group then up here are responsible for initiating movement of the bolus through the esophagus. They wrap around the esophagus, and as the food bolus comes in here, they sequentially contract to move the bolus distally. Let's just have a look at that in a bit more detail. Sorry. So here's the hyopharyngeus, the thyropharyngeus, and the cricopharyngeus. And these muscles contract in sequence, 1, 2, 3, as we'll see here. And it's this that initiates the movement of the food bolus through the cranial esophagus into the distal part. Now, this is a really, really important function, which as laryngeal surgeons, we need to understand, because if we damage this muscle, the thyropharyngeus, during surgery, then we're likely to have lasting dysphagia and regurgitation and complications. So in cross-sectional sequence, we can see here the hyopharyngeus, the thyropharyngeus, and the cricopharyngeus, which function sequentially when the food bolus arrives. It'll be here soon. Where is it? Here's the food bolus. There's the sequential activity. Now, if we damage this muscle, it doesn't contract. And what happens is this. We start to see regurgitation. So we need to be very careful during our laryngeal approaches not to damage this muscle. We need to understand what these muscles actually do. Quickly then, to finish on the anatomy, let's just remind ourselves of the innervation. The innervation of the larynx is via the vagus, which provides, first of all, the cranial laryngeal nerve, which is sensory, and then the caudal laryngeal or recurrent, which is motor to the intrinsic muscles. Let's have a look at that in 3D. So here's our 3D system. Here's the vagus giving off the cranial laryngeal nerve, which is sensory to the mucosa of the larynx. So if any debris falls on the mucosa, it will initiate a cough reflex through this sensory nerve here. So it's a purely sensory nerve. The vagus then continues, of course, down into the thorax, and returns as the caudal laryngeal, or as the recurrent laryngeal, which is purely motor. And so it's this muscle which initiates activity in all of the intrinsic muscles. Now, I think this is quite an important point, because when we think about paralysis, we tend to think about the larynx not being able to open. But in fact, in addition to that, the larynx can't close either. So all of the intrinsic muscles are paralyzed, not just one group. So the consequence of diseases or injuries to the caudal laryngeal nerve here means that all of these muscles, all of the intrinsic muscles, both adductors and adductors, are paralyzed. So this means that not only can the larynx not only open during the inspiratory phase, but it can't close during the swallowing phase. And this is why I think we know that the glottic closure is really not a very important protection mechanism, because most dogs that have laryngeal paralysis don't get inhalation problems. So the most important functions to protect the airway are the epiglottis and the ventral movement, care of the extrinsic muscles of the larynx. So let's move on now, excuse me, and talk about laryngeal paralysis itself. What do we mean by laryngeal paralysis? We mean failure of movement of the arytenoids, both in an abduction direction and in an adduction direction. Okay, and there can be various etiologies, the most common of which are usually neurological, but it can be mechanical. There can be an ankylosis of the cricoarytenoid joints, which prevent them from moving. But generally speaking, we're usually talking about a group of dogs with neurological dysfunction of the recurrent laryngeal nerve. And most of these we refer to as being idiopathic. Or we can show the changes in the recurrent laryngeal nerve, but we're not really sure what causes them. We know that the changes are confined to only the caudal laryngeal nerve, unlike the congenital form where there are central lesions. And we regard it as the most important etiology, even though we don't really understand it. And we certainly know that it's associated with these middle-sized breeds that we can see listed here. It has a predilection for the male, and it's a condition that we typically see in older dogs, 10 to 12 years of age, but it certainly can occur idiopathically in much younger dogs, but we tend to think of it as a condition of the older, medium-sized dog. Now, we should probably address this important question of whether the idiopathic form is part of a generalized neuropathy. And I think this is a pretty controversial topic, because quite a few publications have indicated that idiopathic laryngeal paralysis is the first indication, or a forerunner, if you like, of a generalized neuropathy for dogs in the United States. I think there are a group that believe that laryngeal paralysis is part of a neuropathy. I think the experience elsewhere in the world, and I can't readily explain why, but certainly in Europe and UK and Australia and New Zealand, it doesn't seem to be the case. And certainly the first 100 laryngeal paralysis patients that I operated many, many years ago, we followed for 12 months, 95% were alive and well and free of other neurological signs. So I think there are groups of dogs which have different etiologies. And I think there are some that have generalized neuropathy and some which have a local neuropathy. What are the consequences of caudal laryngeal nerve dysfunction? Well, there is failure of abduction during inspiration. Okay, and we see stridor, lack of exercise tolerance, and cyanosis. We definitely see those. Those are the signs that we associate with laryngeal paralysis. Theoretically, of course, because there is adductor muscle failure during swallowing, if the glottic closure was an important mechanism for airway protection, we would see cough and inhalation pneumonia And in most patients, we simply don't see that. So that's why we think that glottic closure is not a particularly important part of airway protection. So dogs with laryngeal paralysis don't have inhalation problems because the important protective mechanisms, namely the epiglottic function and the extrinsic muscles, still work in the presence of laryngeal paralysis. And this, I think, is a really important concept. When patients have problems post-operatively, it's because something's happened to either the epiglottis or to the extrinsic muscles, and not because of this mythical misconception that we've drawn the vocal folds apart permanently. Now let's look at the diagnosis. How can we be certain that we're dealing with laryngeal paralysis? I think some people do recognize dogs that they think have got laryngeal paralysis, but they're not really certain, and therefore they don't go ahead and do the surgery. History is obviously key, and if you've got an older male medium breed dog with noisy respiration, you probably have a 95% chance that there is laryngeal dysfunction of some sort, laryngeal paralysis. The most important, and I think the most informative examination, part of the examination, is laryngeal auscultation. I think it's the easiest thing to do. You take your stethoscope, put it over the larynx. If you can hear laryngeal noise, then it's abnormal. It doesn't necessarily mean the dog has paralysis, but if you do what's being done here and you can hear respiratory noise, it means there's something wrong with the larynx. And if it's a medium-sized dog like this, 12 years of age, there's a very good chance that's going to be laryngeal paralysis. Now, we can do this in the resting dog, and there's really no need to send the owner and the dog running around the car park until both of them collapse just to initiate the respiratory noise. So do think about doing something very simple in the consulting room. Just listen very carefully. Okay, we're going to see some dogs now, or listen to more specifically dogs with laryngeal paralysis. And this first one, I think, illustrates that it's very easy to overlook in the early stages. Okay, so here we have a pointer, 10 years old. And at first sight, we might just think that the dog is just excited to be in the hospital, he's panting, but actually he's been in an air-conditioned kennel for the past 24 hours. He's just come out, and this is how he breathes normally, open-mouthed with noise, and that's due to paralysis. Here's a bit more severe, and more severe still. The signs get worse with heat and travel and excitement. So the likelihood is that by the time the dog arrives at your hospital in the middle of the summer with travel and excitement, he or she will be making a noise like that. In the very severe bilateral cases, we see this. And if we look a little closer at the mucosal surface, we can see that there is cyanosis. Now, this particular dog has got a biphasic noise. Normally, the stridor is uniphasic. So there's an inspiratory noise. In severe paralysis, as in this case, we have a bilateral noise. So there's inspiratory and expiratory, that type of noise. And these patients are the ones which really do become cyanotic and collapse. So I guess the gold standard is that we look at the laryngeal movement. So here on the left is a normal larynx, and we can see the movement of the arytenoid cartilages and vocal folds. Here on the right is a dog with paralysis, and we can see the lack of movement there. Normally, we do this either in the sedated dog or the dog that's very, very lightly anesthetized, so that you can just about prise the mouth open. And I'd always suggest that you get your assistant to do prise the mouth open, because you're going to be needing your fingers in the next few minutes to actually fix the surgery. So here we can see an absence of laryngeal movement. The other features of laryngeal paralysis, apart from arytenoid movement, are we may see this erythematous change because the mucosa will dry out with the turbulent airflow, and you can see this very dilated nasopharynx, which is more indicative of respiratory effort. So I think it's always essential to do laryngoscopy. Good to have the patient really quite lightly anesthetized, and also to have an assistant who's watching the dog's respiratory movements in the chest, so that you don't mistake the paradoxic abduction of expiration for inspiratory movement. Okay, let's talk about surgery and try and put into practice what we've learned from functional anatomy. Now, I have to say that there's a great deal of nonsense published in a lot of textbooks about laryngeal surgery for laryngeal paralysis, and I need to be as clear as I possibly can. I think there is really only one surgery, and that's the arytenoid tieback. And I would suggest, if you've been dallying with other techniques, you have a rethink and try and understand why the procedure we're going to talk about in a moment is the most efficient and the safest and has the best results. So laryngeal tieback, the original concept goes back to the year in which I graduated. It's that old. And the concept was to disarticulate the arytenoid, to disarticulate the sesamoidean band here, and then to attach it to the thyroid cartilage. So it literally goes laterally, hence the original title of arytenoid lateralization. So this is genuinely a lateralization. Now, it's a perfectly good technique in the right hands, and it saved many thousands of dogs. But there is one big disadvantage, and that is that if you disarticulate the arytenoid completely, it is possible to move it too far laterally, so you create a far too big opening, edema here, which the epiglottis can't cover. And this is one important reason for failure of the lateralization procedure. The concept that some is good, more must be better, is quite wrong here, because if you overdilate the larynx, these dogs will have aspiration. So what we recommend now is rotation, which means leaving the arytenoid articulation intact and then rotating it to its adducted position and holding it there with a prosthetic suture which mimics the effect of the dorsal cricoarytenoid muscle. Now, the big advantage of this is, you get a much more stable result, but it is impossible, I think, to overdilate the larynx. Now, most of these patients will be bilaterally paralyzed. We only ever operate one side, and we're not trying to overdilate the larynx. We simply want to give the dog a reasonable quality of life. So here we are looking at the articular face of the arytenoid. We've opened the joint up, but we leave it attached on its rostral aspect here, and we leave it attached through the sesamoidean band to the other arytenoid. And we're going to put our suture through that cartilage there. So that's the concept. The arytenoid remains stable. Okay, here's a 3D animated sequence of the surgery. And so the patient's in lateral recumbency. This is the left side. For a right-handed surgeon, the head's in this direction here. And we're palpating the larynx. First of all, try and convince yourself you know where the larynx is. We'll look at the landmarks in a moment. Make our skin incision. We shouldn't really have very much but subcutaneous fat. certainly no major structures to get through until we get down to the larynx and we can see the extrinsic muscles here, the hyopharyngeus, cricopharyngeus. Now, what we're going to do is separate the fibers of the thyropharyngeus to allow us access to the larynx. Okay, now miraculously, all of this will disappear in a moment. It doesn't happen in real life, but schematically, what we're now interested in is our old friend, the dorsal cricoarytenoid muscle, which should be quite atrophied. And if it's not, you need to be worried about the diagnosis. So we're going to section the muscle in mid-belly, and that allows us to rotate the arytenoid once we've opened this articular surface here into this abducted position, still firmly attached. And then we're going to put in a suture prosthesis to mimic the the dorsal cricoarytenoid muscle. So we come in through the dorsal aspect of the cricoid, emerge through the muscle into the arytenoid articular face and back in a mattress fashion, and then tie that off there. Okay, and that now holds the arytenoid in this abducted position. So let's just look at that again. The suture will come along in a moment. It's going to go in through the cricoid dorsal aspect in this region here and emerge through the remnant of the muscle. Okay, come through the articular face of the arytenoid and then back through in a mattress fashion, and then gets tied off at this end here. So what that does is leave the arytenoid in its maximally abducted position. And I say maximally abducted, I mean within the physiological range. Okay, one or two key points of that. In terms of patient position, the patients we saw is in lateral recumbency with the cervical pack. The head is at this end. If you're a right-handed surgeon, you operate on the left side. If you're a left-handed surgeon, operate on the right side, because we're hopefully only going to do one side. So the dominant hand is always working towards the front of the dog. It makes the dissection a lot easier. The site for the incision is really crucial. If you get it in the wrong place, life becomes difficult. So we occlude the jugular. Here we can see the bifurcation of the maxillary and facial lingual. We make our incision below that. So even if you've got a 50-kilogram fat Labrador, you'll be able to find this superficial landmark, which will allow you then to find the larynx. So as you do the dissection, keep feeling for the larynx. Really important to start in the right place. Okay, now we're down to this muscle here, the thyropharyngeus. And remember, we said how important it was not to damage the muscle. Here we can see the dorsal wing of the thyroid cartilage here. Now we're going to need to make an incision through the thyropharyngeus muscle to get to the larynx. And most people, I think, have done this, which is to make a horizontal incision. Now let's bear in mind that the fibers of the muscle run in this direction. So why do people cut across the fibers? They do it because it gives you a super exposure like that. But it gives you lots of muscle damage. And let's just remind ourselves of what happens if we damage this muscle. If we damage that muscle, we're going to see regurgitation and dysphagia and all sorts of complications post-operatively. So try to preserve the muscle. How do we do that? We make a vertical approach, separating the fibers. It's rather like pulling two curtains apart. And that limits any muscle damage. These patients can eat immediately post-operatively without problems. The downside is you have very limited exposure. Okay, so it is a limitation, but please, when you're doing this surgery and you feel you haven't got good enough exposure, do not resort to cutting this muscle horizontally. Split it vertically and you can get a bit more exposure. All right, the dorsal cricoarytenoid muscle we've seen Here you can see it's very atrophied. If it's not, it means you've got the wrong diagnosis usually. We incise that in the middle of the muscle belly, and that leaves the remnant of the origin of the carotenoid muscle. And so we're going to place our suture through the cricoid here, so that it emerges through this cut edge of the muscle, like this. And we use proline in a Labrador, 2-0 proline. In terrier, you get down to 3 to 4. In a cat with paralysis, you'll need 6-0 proline. But what we're trying to do is mimic this muscle with the suture. Okay, so this is where it should be ideally placed so that the tension is aligned in the normal physiological plane. So the €64,000 or $64,000 question that everybody asks, how wide should we open the rema glottidis? And this is one of the reasons that I think that rotation is so much a better technique, because it kind of answers the question for you. We know that if we don't dilate the larynx enough, the rema is too small, we're going to have ongoing airway obstruction. And conversely, if we do this, which is a lateralization, which has been pulled almost to the dog's ear, we're going to see aspiration, because the epiglottis will not be able to cover an opening like that. So here's the way that I look upon it. On the left here, we have a normal laryngeal opening. On the right here is a laryngeal opening after rotation. Now, what I'm going to do is stop the larynx in its maximal abduction phase, and I'll stop this moving as well. So in normal respiratory function, this is as big as the larynx ever gets. Okay, so it's not a case of making it as wide as possible so that we have a really huge larynx. So if we look at the area of that rema, that's comparable to the area of the unilateral rotation. Okay, and that I think is the best way to explain it. If you maximally adduct the arytenoid whilst it's still attached, then there's no possibility of over dilating it. So this is what we should be looking for. It's not going to be the size of a huge tunnel under the channel. It needs to be about the same size as the normal physiological opening. Okay, so what's normal? This is normal. Okay, we don't want a hugely open larynx. All right, let's deal with some of the myths then, based on what we now know about laryngeal anatomy. One of the most common myths that we see in textbooks, and one still circulating, is after surgery, dogs can inhale food because the larynx is open. And I need to tell you that this is a bullshit theory, which is promulgated by surgeons who haven't done a very good job. It is not the case that rotating the arytenoid will allow inhalation. These dogs should not be having aspiration problems because, once again, the epiglottis is doing its job and the hyoid and the extrinsic muscles should still be working. So together, if the epiglottis is covering the rema and the extrinsic muscles and the hyoid are moving the larynx out of the way after surgery, these dogs should not have problems. The reality is that we do from time to time see surgeons have difficulty with this, and they have dogs that have dysphagia and aspiration pneumonia. The unfortunate truth is that these only happen if either the thyropharyngeus muscle has been damaged and there is a swallowing dysfunction, or the rema is too large and the epiglottis cannot cover it. This is the only way that complications can happen. It's nonsense to try and blame it on the larynx being open. It's a consequence of poor surgery. Now, for me, tieback is a day case. So the patient comes in first thing in the morning, has his bloods, chest x-ray, surgery mid-morning, recovers around about lunchtime, and then we feed them. And the reason that I insist on feeding these dogs immediately post-operatively is, one, yes, it's true, I like to see that there is no dysphagia or dysfunction. But number two, and much more importantly, most of these dogs are Labradors who've been starved for 24 hours. So they're hungry, they're away from home, and a hungry Labrador that hasn't got mum or dad around will start to vocalize. So we normally feed them. So here we can see a patient that's just had surgery coming back, and pretty much as soon as it's awake, we'll start to offer it food. We usually do this with bolus of food like so. And you'll see in a moment, not very interested to begin with, but you'll see that it's perfectly capable of swallowing the food within a few minutes of recovering from the anesthetic. So dysphagia should not be an issue for these patients post-operatively. So let me do the take-home messages. Number one, laryngeal tie-back surgeries, laryngeal rotation is a minor intervention. It's a minimally invasive surgery with few complications, providing you understand why rotation works and how it works. The dog's quality of life will be normal immediately post-operatively, and even working dogs can go back to hunting and obedience and so on and so forth. But they'll always make a little noise because the turbulence is still present to some degree, but the vocal folds don't move, they're fixed, so you have some turbulence. Okay. The final take-home message, I think, is that it's a minor intervention. It's not a difficult surgery, and I've taught plenty of boarded and non-boarded surgeons to do it if you understand laryngeal function. And I think this is the critical part of tonight's chat, really, is that if you understand functional anatomy, then everything kind of falls into place, and you understand how to avoid some of the very common pitfalls of laryngeal surgery. Good. Okay, so I think we can take some questions, Daniela. If I'm still attached, I think I am. There we go. Daniela, back to you.
So thank you very much. Absolutely, it's an awesome presentation with the 3D function. So I have a question, guys, because usually we have to wait for some of our.
So usually the first difficult, the question is the most difficult.
No. It's just because some of these dogs have also dysfunction of the upper esophageal sphincter, not because it's not only the laryngeal recurrent, but it's also the paralaryngeal nerve that is dysfunctional, and this made them regurgitating also, right? So, and have you ever had any concern about that? So independently from the damage that we could do surgically, but if they have, because there is no way that we can test the function of the paralaryngeal nerve.
No, I think that's true, but I have to say, I think the number of dogs that end up with paralaryngeal dysfunction are relatively small. We're talking about a handful of percent.
Okay.
And I think, we need to make a distinction between that possibility, which I think is quite unusual, and the more common explanation for dogs that have regurgitation post-operatively, which is that, a surgeon has taken a big pair of Mayo scissors and cut the pharyngeal muscles horizontally. That's, it's astonishing that any function returns to those muscles, really. It's a good job it's a bilateral thing. So yeah, it can happen, but I think it's a relatively rare situation.
Okay, thank you very much. Paolo, any questions from the
okay, so from Davina, she says, I'm interested in what we think about these dogs that present with retching and gagging. They often come through medicine. Correct, they do. Yeah, I think there are some that have, I think, more complex problems than just laryngeal paralysis. And, as Daniela was saying, some of them do have symptoms of retching, gagging pre-operatively. Those that where I think there is any doubt about swallowing function preoperatively, I think like Davina, I don't like to do tieback on those. I've got too old to have dogs with complications. So I'm not really sure what the solution is for some of these dogs. And, you know, occasionally you see dogs with megaesophagus and so on. I think they probably are just not candidates for tieback surgery. What does Davina think?
Hello, have we got Davina? Can you let Davina come in, please?
Or just type it in?
Or type in, yeah.
No, that's fine. I'm just putting myself here. I'm here. Well, I don't know. I mean, if they haven't got exercise intolerance, then I'll say to the medics, I don't want to do this. And I think sometimes when they finish their workup, they then find that they've got some sort of dietary intolerance. And I think probably they're actually refluxing and coughing and gagging because they've got sort of acidic burn in the back of the throat. And then they also happen to have either a very swollen larynx, so it doesn't move when I'm looking at it, and it looks like it's paralyzed, or they also have early laryngeal paralysis because it's a 12-year-old Labrador. And those dogs, I hold off, and then eventually you feel you've got to do something because they're really beginning to roar and they can't walk very far. And tie them back, but I just feel very uncomfortable about it. And I feel incredibly uncomfortable about tying back or doing tiebacks on dogs that have any indication of sort of IBD type problems. I think that we don't fully recognize the irritation of reflux in the back of the throat. We obviously see that in the French bulldogs. Their airways are made worse by their reflux, because when you look at it, it's all bright red and swollen because of all the acidic issues there. And I think we probably don't recognize it very well in these dogs that we make an easy diagnosis because it's obviously got laryngeal paralysis, and we forget that he's been hiccuping acid to the back of his throat every night and his larynx is actually really swollen. I don't know how you unravel that unless you insist that anything like that has to be put under control, and then you have another look at the larynx and see if now it can move.
Yeah, I think sometimes sending them back to medicine is the right thing to do.
All medicine cases should go back to medicine before they get cut, I think, just quickly, just in case.
No, I'd thoroughly endorse it. I mean, I think there are dogs that just are not candidates. And I think if they have any dysphagia preoperatively, you're just asking for trouble. And then it becomes a surgical failure as opposed to a medicine misdiagnosis. I like Paolo's comment that it's an interesting topic, even for an internist. So that's a high praise, that is.
Yeah. Because Paola is an internist. So, so whilst we are waiting for other questions, I guess, Paolo, just if you can, here there is Asmia Husejnovic.
Right. So the question is, are you going to do tieback surgery on patients with aspiration pneumonia? Well, I think the question really, and this goes back a bit to what Davina was saying, is why do they have aspiration in the first place? Because it's not due to primary laryngeal dysfunction. So, if there's an identifiable reason for the aspiration and you can manage the aspiration, and that's a one-off event, then yeah, you are going to do the tieback. But I think if you have an undiagnosed cause for the aspiration, I wouldn't. But one of the things I want to stress on this talk is that if dogs have aspiration pneumonia, it ain't just due to laryngeal paralysis. There is something else going on, and you need to look for it.
And is it true that, I always thought that if you immobilize or rotate that arytenoid and the dog has pneumonia, he then can't cough properly? Is that right?
Well, I think
can't build up the.
There's no closed glottis for it to forcefully. You do reduce the cough reflex. Whether the dog's better off with its laryngeal paralysis and can cough a bit, or whether you should fix the laryngeal paralysis and prevent the cough, I'm not sure. But if there is an underlying cause of the aspiration which is not identified, it stays as a medicine case as far as I'm concerned.
Vicky has got a question as well.
Vicky.
Yeah, my question, you mentioned stenosis ankylosis as being really rare at the beginning, and I wondered if you'd seen many cases and how you differentiate it from paralysis. And
right, so I think they are rare, but they do turn up. And so you might find an old Labrador with what looks like a laryngeal paralysis. You go to surgery and you discover that you need a chisel to shift the arytenoid. And whether there's been some kind of trauma or an inflammatory episode, I don't know. They are not that common, but they do turn up. And from a surgical point of view, as I'm sure you know, pretty disconcerting when you have to start dissecting through fibrous tissue to find the arytenoid. I mean, if you can get the arytenoid moving, then the surgery will still be successful, I think. But where you have to actually detach the arytenoid, those are the cases I think they're not going to do so well.
I've definitely had one not do so well. Long time ago, because they don't come very often, but I remember being very confused by it and hoping that I see one again for a really long time.
Yeah, they don't turn up often, but it can be a bit of a nightmare.
Also,
how are you?
I'm also disappointed by how the muscle is atrophied, the CAD muscle, but it still bleeds, and I always think it looks more chunky than it should, considering that it should be completely disappeared.
Yeah, I mean, it depends obviously on the longevity of the paralysis and so on. They do bleed. I perhaps should have emphasized that a little bit more. If they're atrophied, they tend not to bleed quite so much. But having some cut-in diathermy there is a useful thing to do. Yeah.
Thank you for the question. So I just would like to thank you for those of you who have donated during Professor Dick White lectures, and I would like to invite more of you to just donate a little for our cause. So again, click just on the link, justgiving.com/vets4Ukraine. And so you can see the link here. And in the meantime, we have another guest who is Tatiana Kramova. I hope I have pronounced the surname correctly. And
almost.
Hi, Tatiana. Tatiana is she's a vet. She's an Ukrainian vet. And actually, I don't want to say too much. I would like to ask Tatiana to introduce herself and to tell us her story, if this is okay. Tatiana.
Good evening to everybody, and thank you, Daniela, for having me here, and thank you, Professor White, for your interesting lecture. It's an honor for me to finally meet you online. I still remember your marvelous lecture at NVC in Moscow in 2015. One of the lectures was actually about laryngeal paralysis, and I still have it. So good. Yeah, it's a pleasure for me to meet you. So a few words about me. I used to be a soft tissue surgeon and surgical oncologist in Ukraine. So kind of specialist, but not a diplomate of any colleges. But I used to work as a referral surgeon. But on the 24th of February, my life changed completely. And I'm from Kiev, and my city got bombed, and there were missile strikes on it. So I spent 5 days of such a life, and then I've decided to leave my country with my family because it was too dangerous for me to stay. So me, my old mom, and my dachshund, we left Ukraine on the 2nd of March. We crossed the border of Romania, and now for almost 3 months I'm staying here in Bucharest. My friend Vitalar Bogdan Alexandru from Bucharest, he has invited me to live in his house, and I spent there for more than a month, and now he rented me an apartment where I'm currently staying. And by the end of this month, or maybe at the beginning of June, I hope to relocate to the United Kingdom. We already have visas by Homes for Ukraine program. I just have to collect all the papers for my dog. It's really hard to import a dog to the United Kingdom. So I really hope to meet all of you in person.
Thank you, Tatiana. You're very welcome, and it's a very good news that you are managing to move to come to the UK. Just what I wanted to take in the example of Tatiana, I just wanted to comment on the fact that with our initiative, with our webinars, now what I have noticed, and maybe I'm not the only one, I hope I'm not the only one, is that how somehow the colleagues in East Europe are still somehow, if you pass me the word, a little bit a different world from us. So we don't have many diplomates, at least talking about the European College of Veterinary Surgeons. We don't have many, actually, I don't think we have Ukrainian colleague diplomate in our disciplines. I'm aware that there is a recent diplomate in oncology who is Natalia Ignatenko. And I just wanted, because we are here really three very important representative of the college, so Davina, Vicky, and Professor Dick White, I just wanted to maybe just ask a question, what in their opinion would be a good way to start to promote the ECVS program and start to have more and more people from East Europe doing this training. So is there a way to make things easier, or is just the geographical localization and the visas and everything? So what do you think?
I think I can probably say a little bit about this because I've been a bit involved with it. So both EBVS and ECVS have initiatives where they have local country representatives trying to get people to take on training programs. Obviously, if you've got no ECVS diplomate in your country, then you can't run a program there. But the EBVS requires all the European colleges to offer alternate route residency training programs to anybody who cannot do a residency training program in their own country. In the UK, it's very difficult to get onto an alternate program because we've got dozens of residency training programs. But if you're coming from a country where you can't get to a program, then there are many programs throughout Europe that will take on people on the alternate route. So you do surgery in your own clinic, and then you spend chunks of time under the direct supervision of a boarded diplomat in a clinic in another country. So I know that there are programs in Vienna and Italy and the UK and Ireland where they're running alternate programs. And you can do it over a longer period of time. You're not expected to do it over the 3 years because you can't get, the training and the support in that time. So there is actually quite a lot of initiative of trying to get more and more people involved in European colleges. And most countries have a European diplomat in a discipline, not necessarily surgery. And then the EBVS try and get them to get more publicity about the European colleges. And then from there, somebody says, well, we've got a dermatologist, we've got a radiologist, I'm going to try and become an ECVS boarded surgeon. So that's how they're trying to do it. But I mean, that's been an initiative that's been going on for the past 5 or 10 years. It's just very slow.
Daniela, you're muted.
Oh, here you are. Thank you. No, what I was commenting on what Davina was saying, so that remembering my past experience in the credential committee at the ECVS, there were programs like alternate programs in countries like Cyprus, where they don't have a program, and then the residents were trained among basically in Israel, to where there is a diplomat in Israel, and to try to have a diplomat then in Cyprus to start a program there. So I don't know if this is, Tatiana, this is useful to know for you, because you were also interested in undergoing or taking such a path. Yeah.
Yeah, I've heard about alternative route of doing residency, and I know there were some Russian veterinarians who did it, like Ekaterina Kuznetsova, who did an alternative residency in dermatology. Well, unfortunately, having the war in my country makes things a bit difficult. So I hope to do residency in surgery being in the United Kingdom, but the main problem for the moment is that our Ukrainian veterinary degrees are not recognized by RCVS. So I will work as a veterinary care assistant, back to basics, let's say, and I have to sit and pass, hopefully, the RCVS tutor membership exam, and then I can hopefully proceed first to the rotation internship and then to the residency in surgery.
Good. Well, if you need any tuition that you think a very old professor can give you to help you get through the RCVS exams, as a previous RCVS examiner, I'll be very happy to help you when you come to the UK.
Thank you.
And I think I speak for everybody here tonight. We'll all be delighted to help you.
Absolutely.
Yeah.
Everybody's nodding. Yeah, we look forward to meeting you.
Thank you.
Absolutely, yes. Are you happy? Do you have any questions for Professor Dick White, Davina, or Vicky, Tatiana? Have you got any surgical question you would like to?
No, I think not.
Okay, yeah. So yeah, I think we are very, very delighted to have you here, Tatiana. You represent basically our category in difficulty right now. Paolo, have we got any other questions for Professor Dick White? No, not yet. So I have another question that goes a little bit beyond the laryngeal paralysis. It's just more, and again, it's a question open to everyone. So with there is this word that right now is trendy, is like leadership, being a leader. What do you think are now the requirements nowadays to be a good leader in our profession? It's like a 7 million
7 million question with a grenade with a pin taken out of it. I think really the most important quality for somebody who wants to lead is you have to have a vision. You know, you have to know where you're going and then try and take people with you. And I think, you know, in far too many situations in our profession, we see lack of vision, lack of, you know, we're here, we really want to be here, and this is the route to get it. You know, people who try and work out strategies for clinics without knowing where that strategy is going to take them, as you can probably tell, really irritate me. Leaders need to have a vision. I think that's the most important thing that I can probably distill from my experience. Have a vision and try and take people with you.
Any other comment from Vicky or Davina? Or?
Yes, I guess, well, there's really only two things you need to do when you get to that level of leadership or management. And one is to have a vision and the other is to communicate it well. And so I guess the thing that I add to that is I try and have a happy team, because basically everything else will fall into place. If people are happy, they'll work well, they'll do all the things they need to do. Not always easy in our profession with all the challenges that we come across. But that's what I try and have alongside the vision is to try and have a happy team.
I think also you need to be prepared to set the tone, be consistent. I mean, you know, Dick always set the tone of how he wanted the clinic to run and was prepared to, you know, if he said everyone we're going to do it this way, then he did do it that way himself. It's like parenting. You have to have consistent parenting. And I think, and that sounds incredibly patronizing about your team, but one of the things I remember as a resident was we were standing in the ward, and a student was presenting the case, and the dog urinated all over the floor, and it was Dick who picked up the mop and cleaned the floor. And I always remembered that, and I made a point of, if I got my dog out of the kennel when I set up my own practice and there was diarrhea everywhere, I tied it up and I got the gloves on and I got on my knees and I cleaned that kennel. Somebody might come and stop you and say, for God's sake, you've got better things to do with your time, let me do that. But the point is, I demonstrated that I was prepared to do it, which meant that everyone else is prepared to do it.
I must say, you're spot on, Davina. I think if people have seen you cleaning the dog kennels at 4 o'clock in the morning, you can never be afraid to ask them to do the same.
These words are really gold, or I would say diamond dust, because nowadays, you don't see many people doing that. So, and because there is a misconception that this type of job belongs to someone else and not to us. So thank you for saying this. Thank you, Davina, because it's really, really important. It's a really important message for the young generations. And talking about the vision, obviously, when you did found your own referral hospital, so your vision was, we still know it, is excellence, trust, or care and trust. Can I ask you to give us your definition of these three important words?
Not easily on a Sunday night. It's interesting that we've been running the clinic for some years, and somebody had the bright idea that we needed to have a brand for the clinic, and so you get these branding guys in, and they go and ask questions, and they talk to people you work with. So those three words came out of what colleagues thought and about what clients thought about us. And it ain't rocket science. If you care about the patients and the outcomes, then people will see that immediately. It doesn't matter what profession you're in. If you're engaged and you care about the outcome, people will always see that. I think that's enough for a Sunday night. Come on.
Okay.
It's Chardonnay time.
Okay, so Paolo, any questions from the audience? Nope. Hi, Petra. I hope you are well. Thank you, Petra. Oh, Raffaella, the link for the donation, you will see now, if Paolo is so kind to put it again. Yes, it's this one, www.justgiving.com/vets4Ukraine. Come on, donate, because we are really nearly to the 5,000. So thank you to everyone who has donated tonight, and please just keep doing it. I don't want to keep our guests longer because I know it's Sunday night, and
we just need to reiterate the quote from Bob Geldof years ago, which was, "Give us the bloody money."
Yeah, okay, maybe. Okay, give us the bloody money. So I just I think that our next thank you, Johnny, thank you. And our next live will be on, I think, internal medicine, on I think on in urinary incontinence in dogs, and I think it will be on Wednesday, but I need to check the dates. But we will do the usual advertisement. What to say? So Davina, Vicky, thank you so much. it was really, really kind for you to join us. I do really appreciate, and thank you. And Professor Dick White, thank you so much. It was a great talk.
Well, thank you for inviting me and for giving me the opportunity to participate, and thank you to all of the colleagues for the wonderful things they said about me, however untrue they were.
Yeah. Thank you to everyone, also Davina and Vicky, who have already done their talk. And remind all the talks are recorded and are on the YouTube channel Vetonea. So you can find Davina, who spoke about the spay in dogs and cats, the pro and contras, and Vicky spoke about the wound management. So all very important and very good talks, high quality talks, and just spread the voice and obviously donate. Tatiana, thank you very much as well for being with us. It's been a pleasure to see you in person. I think to all of you, take care. Thank you so much, and bye-bye. Thank you. Thank you.